Okay, Assalamu alaikum. Welcome everyone on board because I had not switched on the recording. So I will introduce myself and Bilal again. I'm Dr. Zishan. I am a consultant anesthesiast, Prince Sultan Military Medical City, Riyadh. Today we are honored to have Bilal Tufail, who is working as a consultant in US. He's assistant professor at Albert Einstein College of Medicine. And we are lucky that Bilal will be teaching us obstructive sleep apnea. So, Bilal, are you ready?
Yes.
Bilal, I cannot hear you. I don't know.
Hi. Can you hear me
Hello.
now?
Yes, Bilal, we can hear
Hello.
you. So I humbly
Okay.
request all of you to please mute your mic so that we are able to listen to our speaker. And Bilal, I
Okay.
think you can start, please.
All right. Okay. So I guess it's evening over there. So good evening, everybody. And here, just we started noon over here in the New York. It's at 12 p.m. Eastern Standard Time. So a little bit about me. My name is Bilal. I was graduated from Punjab Medical College long back, like more than a decade. Uh, then after a couple of years struggle, my educational background is very humble and not very bright. So I came into the system again around 2014, started as a resident of anesthesiology with Call and Associates. Uh, almost an year I worked with them, and then I switched my residency with Shogaf Khanam. They were kind enough to take me as a resident there. I was graduated again with my FCPS in 2018. Worked as 6 months in Indus Tribe in Lahore, and then I went to Middle East to explore more stuff. And I work in King Faisal Specialist Hospital in general and liver transplant division, and reopened the books again, started from the scratch. Uh, Read again all basics, done steps, and came to US. Did a fellowship in advanced airway and ENT anesthesiology for 14 months. And based on my credentials, I was exempted from formal training program, and they hired me as a faculty over here in the Bronx. I'm working in Montefiore Hospital, which is one of the biggest health network in the Bronx. Bronx is one of the 5 borough in the New York, and it's almost an year I'm working over here. So I'm just gonna move my next slide. Let me know if you see the next one. Can you see the next one?
I think no.
That's the problem. That's why okay, so I think I need to move it manually. Can you see it now?
Yes, yes. And maybe you can you can enlarge it so that maybe the visual will be better.
How to do it?
Just make it screen slide screen. This one.
I did it already. Like a small champion cup down, right?
Yes, it's not
I
showing.
click it.
I'm
I
not sure.
click it.
I think, anyways, no problem. I think we will have to bear with it.
Okay. Oh, so nothing to disclose from my side. It's entirely a teaching program. I'm not being favored in terms of finance or any funding for that. And sleep apnea, being airway trained, I have a special interest in that because I have been doing bariatric surgery list and sometime ENT list for some uvulectomy, some hypoglossal nerve stimulator insertions over here. And in the Bronx, we have quite high BMI people I was lucky enough to manage like very high BMI, like 85, sometimes 95. Maximum, I anesthetize a patient for uh, sleeve gastrectomy with 750 pounds. So let's start from the basics. Uh, as per definition, BMI is kilogram divided by meter square height. So there are different grading. I took this slide from Oxford anesthesiology book. So probably most of the people know the bracket of underweight, normal weight, overweight, and morbidly obese. But in this updated edition, you may see a super obesity definition, super obese, and hyper obese. But again, the more focus on this slide is that if we talk about the morbidly obese people, this classification says that morbidly obese people have a BMI somewhat from 40 and below 50. Sorry.
No, no, sorry, Bilal. You can continue.
Okay. So, but if someone is having comorbid conditions like pulmonary hypertension or congestive heart failure or complicated diabetes or hypertension, so definition changes here. So if someone is having comorbid conditions and even somewhat between 35 to 40, we label them morbidly obese as well. So here is a learning point in this slide. And if we talk about WHO classification of obesity and ASA, it's pretty simple if we compare to the previous one. So up till obese, it's again till BMI of a 30, but the main teaching point in this slide is that if someone is class 3 obesity, they are always ASA 3 grading, which means that they are having pretty much high risk for perioperative cardiopulmonary complications. And probably if we are working in some reasonable system, anyone who is morbidly obese, they have to go through the multidisciplinary team assessment for preoperative optimization to have a better outcome after the surgery. So anyone who is class 3 obese or morbidly obese, we tag them ASA3, and they have to have formal like cardiology clearance, pulmonology clearance. If we suspect that they have OSA but they are not diagnosed, try to evaluate them with the sleep studies and other specialty opinions. So obesity is always, should be in our mind. The reason is that it's very important. There are few key points which I took from this paper from BGA. It was published a couple of years ago, and the key point says that obesity only increases periop risk significantly when somebody crosses BMI of 40. Okay. And of course, we should be more careful if someone is having BMI of 40 and also carrying some clinical conditions like diabetes, pulmonary hypertension, COPD, sleep apnea, OHS. What should I say? Like anything, like limited functional capacity, anything. And another question or point to be considered is that, so day case surgery, like if you are working in some ambulatory center, so we have to be very, very careful if someone is having BMI more than 50, because it's very hard to send them home on the same day. And obstructive sleep apnea and obesity hypoventilation syndrome are common high-risk conditions that influence management of anesthesia. For example, it's very hard to put standard monitors on them. It's very hard to control their airway at induction or upon emergence. It's very tricky to plan their analgesia. It's very tricky to decide their post of destination. Like they will go to normal PACU, they will go to step down, they will go to HDU. Do they really need a CPAP, post-op? So these are few concerns which can give you hard time. And probably it's a common practice. I'm not against it that most of the people uh, in certain centers they have their own safety cultures, but literature says that RSI should not be routine in absence of some specific conditions. But again, it varies from country to country. If you are not comfortable to bag mask ventilate some obese uh, patient and you're afraid that they're gonna desat quickly, it's okay, you can paralyze them. And choice of relaxant again depends on the available facilities. So I don't mind that if someone use succinylcholine or rocuronium, but you should have a backup plan. And the key is that how you execute the safe practice. And previous bariatric surgery has important implication for subsequent anesthesia, because if someone is already have a sleeve gastrectomy or someone has a gastric bypass, so I guess they are more prone to aspirate. We should be more careful about their NPO status. And these days, a lot of people are on injectable, weight lowering drugs like Ozempic and so. And even we have come across certain situation that people who are on GLP-1 or GLP-2 and they are morbidly obese and they come for a surgery even after substantial hours of nothing per oral status, still they have full stomach, because here in the New York or in the States, people try to scan their stomach in supine and right lateral position. If someone is having a more than 1.5 ml per kg residual volume in the stomach, we consider them full stomach. And even we have modified few guidelines. If we cancel such case, we ask them to stay NPO for 8 to 10 hours and try to be on clear liquid diet for at least 24 hours to mitigate the risk. But again, it varies from case to case. It varies as per your teaching, as per your local guidelines, but it is always safe, or it is always recommended to keep their aspiration risk evaluated case to case and act accordingly and take a proper clinical decisions. So most of the time, if we see someone is obese, the next question comes to the mind: what co-mobs they have? So if we divide broadly based on system, if we look at the respiratory system, they may have OSA, they may have OHS. OSA is obstructive sleep apnea. OHS is obesity hypoventilation syndrome. So these two conditions are very closely related. And most of the data shows you that it's very hard to see some obese person. It's very rare that they have isolated OHS. If someone is having obesity and OHS, 80% times they have associated OSA as well. And especially in third world countries, it's hard to get sleep studies and further evaluation to tag them as a OSA. But still, there are few questionnaire. It's very easy to screen these conditions. So second most common condition is asthma. And if you look at a CVS, they may be hypertensive, they may have some left ventricular impairment, right ventricular impairment due to ongoing pulmonary hypertension. They may develop cardiomyopathy, they may develop right heart failure. Again, the main thing is hypoxia, which is causing pulmonary hypertension, and which is continuously putting strain over right heart, and ultimately they develop right heart failure. And of course, they are physiologically difficult airways, which means that they are very obese, they have less FRC, They have they have a lot of adipose tissues, which is dependent on oxygen. So their apnea to desat time is quick, and they rapidly desat. So we should be very, very careful while controlling their airways. Sorry, what is question?
Bilal, the mic was on for someone. Bilal, I will just disturb you for a second. Let's try. Maybe you double click it. Someone just put the advice that if you make the PPT slide big by tapping the slide, just try it. Or there is a like enlarge button on the top. Let's try from there. Maybe you will. And another
Which
option
one?
is there. You see here, 97% is showing. Maybe you try to increase. Maybe it will.
Uh-huh.
I think size is a little bigger now, or no?
No.
Okay, so
Is it okay? They can see
yeah,
now?
yes. So we can make zoom the slide from our side. Okay, yes,
Wait,
yes. That's a good advice, Abdullah. So thank you. So pardon for this. Yeah, Bilal,
no
it was
problem.
going out
I
of
know this
the.
is very busy slide and people want to look at every stem of it. At the end of the talk, I can email you this whole talk.
Okay,
So if
I
someone
think
wants
okay.
slides, it's not a big deal. Okay. Any questions? Any concerns? Or should I keep talking?
Continue, I think.
Okay, so metabolically wise, they are diabetic. Maybe they have metabolic syndrome, which is again combination of diabetes, pre-diabetes, hypertension, um, dyslipidemia. Of course, they have obesity-related liver involvement, which is NASH, which is very dangerous. And if someone who is coming for bariatric surgery, it is very important the surgeon put them on some liver shrinking diet, like they ask them to reduce their calories less than 1,000 per day. So it really helps, because especially if someone is doing uh, laparoscopy on them, there is always risk of liver damage while abdominal instrumentations. So these are the common conditions. And of course, everybody knows the feature of hypertension, right heart failure, left heart failure. I'm not going to go into its detail. And of course, these are the few actions written on the right side column, that if someone is having OSA, so it's always better to have pulmonary function test, a blood gas. If someone is having CVS involvement, it is always good to run a EKG on it, get a fresh echo done, right? Ask cardiologists, what are your thoughts about it? Can we optimize these patients? They need any help before we schedule them for some procedure? And there are so many ways to assess somebody functional capacity, like simple questions about, are you able to go up to 2 flight of stairs, can you walk down few blocks in a street. uh, uh, we can do some ask about 6 minute shuttle walk test. Some people, if they are really showing low signs of functional capacity, uh, people ask them to go for CPAT, which is cardiorespiratory pulmonary exercise tests, which tell you about uh, apnea threshold. So basically, in this test, they try to evaluate what is the oxygen requirement divided by CO2 production. So they just want to look at the apneic threshold for that patient, which is really helpful. And if somebody is diabetic, of course, finger stick glucose test or glycated hemoglobin is important. So these are few conditions. If someone is obese and we suspect that this guy may have OSA, so it is always recommended to screen these clinical condition on history. And if you find something significant, there are few actions we can consider to take it. Okay, so I'll move to the next slide. obstructive sleep apnea, just basic of it. Basically, what is this obstructive sleep apnea? Like people, when they fall asleep, their upper airway tone they lose the tone, and they obstruct for a while. Their CO2 rises. It crosses the blood-brain barrier, so respiratory center is stimulated. They wake up again. They regain the tone of upper airways. They start breathing. They hyperventilate. They fall back sleep again, and this vicious cycle keeps on happening again and again. So, by definition, OSA is cessation of airflow at mouth or nose85%. Sorry.
I'm sorry, I think I was disconnected, so maybe you can repeat
Should I
for.
keep talking or stop?
No, 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 no. Keep talking. We were disconnected for a while, so maybe you can just repeat a few last words.
Few last words. Okay. So prevalence of OSA in obese people is 85%. And if we talk about isolated central sleep apnea prevalence, it's 15%. Otherwise, if someone is having central sleep apnea, most of the time they also have OSA. So this is very important. I will clear these two concepts as we proceed in our talk. So let's talk a little bit about sleep physiology. What happens? Who is controlling our sleep? How we wake up? How we fall back to sleep? So probably ascending reticular activating system is concerned with wakefulness, and inhibition of ascending reticular activating system via this complicated name of nucleus, it causes sleep. Okay, and these two areas of brain always work reciprocally to maintain balance of sleep and wakefulness. Okay, and timing and duration of sleep. So during sleep, what happens? Adenosine is a chemical which builds up and we get awake. Okay, and circadian rhythm is that when we go to any time zone, our brain changes these chemical like adenosine, melatonin, and always sleep pattern goes to the baseline. If we are not doing unusual, like there are few environmental trigger, like some people cannot fall asleep if there is intense light. They're always habitual to keep light very dim or keep light shut in the room. Core body temperature is very important in sleep hemostasis. If you take caffeine or coffee or something, any stimulant in late in the evening, it's hard to go back to sleep. Body position is very important for some people. Some people are habitual to adopt a certain specific position to fall to sleep. And of course, environmental stimulation is also important, like in noisy environment, in interruptive environment, it really bothers to someone. They don't fall asleep. But people who are born in a noisy environment in some busy areas, they don't bother it at all. So on EEG, like we can always appreciate these changes if someone is doing some advanced neurological monitoring even during neuroanesthesia. So broadly, the sleep, there are different stages uh, of your conscious level or before you fall back to sleep. So one is wakefulness. We are awake. We can appreciate environment changes everything. We are aware of everything which any awake person do. And then when we get a little bit drowsy, we enter into REM sleep, which mean the rapid eye movement. And then we go to the deep sleep. And deep sleep has further division N1, N2, N3. So basically, problem is in OSA that these people rarely go into non-rapid eye movement sleep. They go into REM sleep, and as they go a little deeper, their airway tone drops, their pharyngeal constrictor muscle lose their function, they choke, they try to put some breathing effort, and they wake. So that's why during daytime they always sleepy. And of course, with EEG, a little bit introduction of EMG. So during awake condition, muscle tone is normal. During REM sleep, it's abolished, and during non-REM sleep, it's decreased. Okay, so this basic idea is entirely enough being a perioperative physician. I'm not going to go into its detail. Okay, so rapid eye movement sleep. In this sleep, what happens to your EEG pattern? So waves increase in duration and intensity as sleep progressive. Okay, and then your muscle tone can be tonic or phasic. So basic review of respiratory control during wakefulness and sleep. Basically, when we sleep, how our breathing is being regulated. So in medulla dorsal, in respiratory group promotes inspiration, and ventral respiratory group promotes, respiratory pacing center. So probably people who have central sleep apnea, they have some changes at this level. And this is a basis how we differentiate them. When somebody run a sleep study, it's very easy to diagnose that this person has a OSA or uh, central sleep apnea. I'll talk about it later. So this is actually cycle which is happening during sleep apnea. Basically, what's going on here, when we sleep, obstruction, apnea, hypopnea, right? Somebody may obstruct and they become purely apneic, which means they stop breathing for at least 10 seconds or more than 10 seconds, and they have more than 90% cessation of airflow to airways. Okay, but if someone has more than 30% cessation of airflow to airway, we call it hypopnea. Okay, so what happens when we fall asleep, right? There is increased breathing effort due to partial or complete airway obstruction, which result in reduced PO2 and rapid rise of PCO2. But when PCO2 rises, it stimulates our brain that something is going wrong with you. That person wakes up, okay, and he regains the upper airway tone again. Okay, how we regain it? The dilator muscles of pharynx come into action, and that person hyperventilate to vent out all accumulated PCO2, and saturation and PO2 comes to normal. And again, they feel a little bit comfortable, these patients, okay, and they fall asleep again. And when they sleep, again, constrictor of upper airways come into action, they choke, and again, PO2 drops, PCO2 goes up, and again they wake up. So this is a whole cycle what's happening in obstructive sleep apnea. Okay, and hallmark of OSA is sleep induced and arousal relieved by upper airway obstruction. But why upper airways are obstructing? It's not clear. For example, in literature, they say that male has more incidence or prevalence of OSA. The reason is that there are few studies which correlate the androgen levels with upper airway tone. And they strengthen their statement with this point that ladies in a reproductive age do not have sleep apnea despite of having obesity. But once they go into postmenopausal phase, they develop sleep apnea because their estrogen drops and they have relatively substantial amount of androgens in their blood. So some people are not obese and they have sleep apnea. And on sleep endoscopies, usually there was one ENT surgeon here who was talking to me when I just set up for this talk. Maybe she's aware of it. That when they do sleep endoscopy, they found uvula is very large. They found that their tongue falls back, right? They need to do surgery on that. And once they do surgery, they do very well. So regarding the pathogenesis, why upper airway is obstructing, it's not clear. If someone knows about it, please let everybody know that what's going on. Okay. So another question, commonly asked question in the oral boards in the Viva exam, that how you gonna screen the OSA? The answer is very simple: stop band. Okay, there are few questions. If you do, and if someone score like 5 to 8, it's a very high risk that that patient has OSA. We are just screening it. But stop bank questionnaire is not diagnosing sleep apnea. It's telling you, yes, there is a chance. If someone has a score 3 to 4 on this questionnaire, again, this is intermediate risk. There is 50-50 chance, maybe. And if someone scored like 0 to 2 on this questionnaire, we can say it's least likely. But again, if clinically you having a suspicion that this patient has sleep apnea, we can further investigate in terms of sleep studies and ask some expert that what is your opinion. Okay, so stop bank questionnaire is not for diagnosis of OSA, it's only for screening purpose. Okay, so next question, maybe you are thinking that how to diagnose it. So diagnose, send that patient for sleep studies. Okay, and in sleep studies, what they're going to see? They're going to see the breathing pattern, they're gonna watch the hemodynamics, they're gonna watch the end-tidal pattern, they're gonna watch that how badly patient is desetting from the baseline SpO2 and how many times this patient obstructs, what is the percentage of obstruction, and what is the duration of obstruction during sleep. And the most important thing, the people who are watching these sleep studies, they keep an eye when someone becomes apneic. They note down that when this patient is apneic, is there any respiratory effort or no? If someone is having apnea longer than 10 seconds with 90% of airflow obstruction, but still that patient is trying to breathe, it means this patient is having obstructive apnea. But if someone is having apnea for more than 10 seconds with more than 90% cessation of airflows to airways, and there is no breathing effort, it means this patient has a central apnea. So that's a key feature to differentiate. And there are a few other definitions in on this slide. You can see hypopnea, hypoventilation, and what is periodic breathing. But I think being an anesthesiologist, we need to know these three simple concepts. And of course, on sleep studies, if someone is diagnosed as a OSA patient based on AHI, which is apnea hypopnea index, what they do, they divide apnea episode by hypopnea per hour. Okay. So if someone has AHI less than 5, so we don't consider it that it's not significant. Okay, so this is not sleep apnea. If someone is having AHI 5 to somewhat 12, 15, that's a mild sleep apnea. If someone is having moderate sleep apnea 16 to 30, and if someone is having AHI more than 30, here the real trouble comes in. That's a severe OSA. So, being an anesthesiologist, what you need to look at, you need to ask the patient, are you on CPAP? How compliant you are with the CPAP? When you started sleep at CPAP, your comorbid conditions started stabilizing or no? Okay, of course, based on AHI, the people who are coming in a window of moderate to severe sleep apnea, you have to plan their analgesia, right? You have to plan how you're going to manage them intraoperatively. You have to plan that, are you confident alone to manage them, or you need extra pair of hands? How are you going to recover them? Where they will go? You need some extra respiratory supporting devices. Will you be able to take the tube out? Weaning is challenging for them or not? So, if someone is having AHI in a moderate or severe window, our management changes. So, again, I will repeat, to screen OSA, answer is stop bank. To diagnose or to stratify the severity of OSA, the answer is AHI. How you get AHI? Send that patient for sleep studies. Okay. So this is a simple diagnostic criteria for OSA, right? Run a stop bank questionnaire on that patient. Okay. And again, you just need to stratify that. How many episodes of apnea and what is AHI? Okay, clear? So what are the predisposing factors for obstructive sleep apnea? There can be many, like patient-related factors, anatomy of upper airways, or other developmental or physical factors, any genetic disorders, or any condition who predispose to this condition. So mainly in patient-related factor, more important is gender, which is male, and it is assumed that upper airway constriction is androgen related. That's why male gets a 1 mark on Stop Bank questionnaire and female don't get it. So that is another blessing in disguise for ladies. Your collar size matters, your body size matter, alcohol intake and smoking is very important, because smoking causes a lot of endothelial damages in the vessels, and it is pro-inflammatory, and there is connection of OSA with this inflammatory change. I'll explain in later slides. And physical factor, like somebody with a large tongue, small chin. Typical Asian people outline is that they have small chin. So retrognathia is very important. Mid-face hypoplasia, big tonsils, any problem with the nasal septum, few conditions like Down syndrome, Piri-Robin syndrome, acromegaly, thyroid dysfunctions, and glycogen storage diseases, other connective tissue disorder. So these all factor have connection with OSA. So basically, when we see somebody or we suspect somebody with OSA, their anatomical and physiological factors and their functional status is very important for us. We need to look at, do they have any predisposing conditions, any airway compromising conditions, and most important thing, which can challenge your management, which can challenge your capacity. or which really can help you to help that patient is the status of their clinical condition. Screen them which clinical condition they have. And second thing is that you need to find out that do they need to be optimized for these conditions before we put them sleep, especially if it's non-urgent surgery. Because being an anesthesiologist, there are a lot of pressure on anyone, like surgeons are pushing anesthesiologists that why you're canceling case. Most of the time, the surgeons don't have much relation with the science. They don't. Sorry.
No, Bilal, continue.
Okay. And sometimes the person who is running floor, they push you that don't cancel this case, doc, please, let's do it. And especially in our culture, there are some interpersonal conflicts also. If somebody refuses for the case, maybe your colleague don't respect your opinion, they want to be like man of the game. They say, I'll do that case. Sometimes it goes fine and sometimes it may not go fine. So optimizing of clinical condition is very important if someone is having OSA, and especially if it's purely elective surgery. I think there shouldn't be any rush, and it is always better to block that patient. But again, I'm not teaching here to for the case cancellations or anything, but it is always safe for you and for the patient to keep an eye on important concerns, and you need to know how to mitigate those risks and how to do a successful flight. So if we talk about obesity hypoventilation syndrome, it has few characteristic, like these people always have hypercapnia. Their baseline and tidal O2 are more than 45. Even if you run blood gas on them, you will find always uh, quite above and beyond the upper limit. Upper limit is 40, I guess. They always have a high BMI, at least more than 30. I think there is a typing error. It should be like kg per meter square. I'm sorry for that. I apologize. And they have increase in PaCO2 more than 10 millimeter of mercury from awake spine position during sleep. When they change their position or when they fall asleep, their PaCO2 even turns higher from the baseline. And again, I'm telling, I told many times in my talk before that most of the time OHS occurs side by side with OSA, but there are few patients, like 10%, they may have isolated this condition. So central sleep apnea, I already talked about that. Their clinical picture on sleep studies is same, but only difference between a patient who has OSA versus central sleep apnea, that person who has central sleep apnea, they do not have respiratory effort. Okay, they just give an impression on sleep study that they are passed out, but they're not. And again, once their brain helps them, they regain their breathing pattern and they become a little bit awake. But OSA patient make sure that no one, they also don't fall asleep properly, but then they make sure that no one can sleep properly next to them. So always, if you have someone interviewing in preoperative clinic, I always, if partner is there, I always ask them, you are able to sleep? And they make very funny faces. Okay. So criteria for diagnosis of central sleep apnea, the criteria is same, but in central sleep apnea, no respiratory effort. Why I'm putting these points again and again? Because people confuse them a lot. This is, for me, this is a most important slide. Why? Because this is a very critical decision and most of the people come across this situation. Like we are sitting in a preoperative clinic. Okay, and we have certain times clinical like situations that, let's say we are sitting in a day case setting, right? And we get some patient with OSA. So we ask question by ourselves or by some senior that is it okay to proceed or not? So it is very simple to answer this question. We are in preoperative assessment and two we have two teams in preoperative clinic. Team one got a patient with OSA, okay? And today, the team one who is getting patient with OSA, they find out that this patient has two clinical conditions. This patient is diabetic and hypertensive, but both are controlled. So they can clear that patient for surgery. Next day, they got a patient with OSA and they found this patient has right heart failure. And this patient went to ER for some breathing issues and they diuresed that patient and they put him on diuretic and they send him home. Okay. And still we see on clinical examination that team finds that that patient has pedal edema and there are fine crackles on auscultation. So if it's elective surgery, they should cancel that case. They should say that you need to wait for few weeks. Once your condition is optimized, we will reschedule it. So in other clinic, there is another team, okay? So yesterday they got a patient and when they run a stop bang on the patient, they were saying they have an impression that this patient has OSA. Okay, because let's say stop band scoring for that patient is 7. They say this patient has OSA. And then on medical inquiry, that patient tells that I have pulmonary hypertension. I am on some anticoagulation because I went to Brazil for 8-hour flight and then I have breathing issue. They scanned me and they said that you have clot in your lungs and I'm hypertensive too. Okay, so I guess ideally this patient should not be proceeded for the surgery because we are sitting in preoperative clinic and we are looking at all elective cases and we need to diagnose this patient, send that patient to pulmonologist, book a sleep study for the patient and optimize that patient. And next day, the team two got a patient who scored 5 on stop bank questionnaire and he has controlled hypertension and controlled diabetes. That patient good to go. So in general, when you look at a patient with OSA, second most important concern is screen for clinical condition. And third concern is that try to evaluate that those chronic conditions are stable or unstable. If those are unstable, do not try to anesthetize that patient. I know that most of the time you may be successful for the procedure, but why to put somebody at risk? So, for educational point of view, this is very important discussion, especially in day case setting. If someone comes with OSA. So, if you have any questions, stop me. So if I'll keep talking, so usually I get an impression that people are sleeping, people may be scrolling their mobile on WhatsApp or watching some YouTube or TikTok. So probably if I'm spending some time, if someone throws question on me, I always feel happy and I always get an impression that people are involved. Okay, so please stop me, please try to give me hard time so that we can initiate some important discussion. Okay, and of course OSA and metabolic syndrome have very close relationships. So basically people who are obese, if you look at someone who is like 300 pounds, they look swollen by their physical appearance. because this OSA is very dangerous. Okay, some people, for example, don't have hypertension, but once they start obstructing during sleep, they develop such a bad hypertension. They always tell you that my blood pressure is not being controlled. I started with one drug, now I am on three drugs. I always have headaches. Now I started having some chest pain on and off. Maybe they will start saying my calf muscles hurt. So basically, what's going on? So, what happens, as I told you earlier, when I was trying to tell you the brief vicious circle like sleep, awake. So, as I mentioned earlier, that these patients get rises and tidal and they drop SPO2, right? Sorry.
Bilal, continue.
Okay. So what happens when somebody DSAT, if some patient is having OSA and they fall asleep and during rapid eye movement sleep, their SPO2 drops and then their brain or respiratory center helps them, it wakes them up and then they take a big breath and they hyperventilate. So when they were obstructing, they had a drop in oxygen, right? When obstruction is relieved upon waking up, they hyperventilate, okay? So their oxygen drops and then oxygenation comes up. So this is just like a reperfusion injuries happening again and again, many times an hour. So on this reperfusion of oxygen, free oxygen radicals are released and they stimulate the release of inflammatory mediators. And those inflammatory mediators start producing endothelial dysfunction. When that endothelial dysfunction is initiated, so all atherosclerotic changes starts happening. So that's why they started to develop ischemic heart disease, hypertension, and they are obese due to insulin resistance. They are becoming diabetic. Then diabetes comes into action. It starts affecting their microvascular and macrovascular, complications. So basically, these inflammatory mediators have a strong correlation with OSA. And what why these inflammatory mediators are coming into action? Because of this reperfusion injury during obstruction, desaturation, awake, gaining resaturation, and all these oxygen free radical is a culprit. So interestingly, when somebody is diagnosed with OSA and we put them on CPAP, they are overnight on CPAP, which means continuous positive airway pressure during their sleep. So that pressure is not letting their upper airway to obstruct, and they come out of this vicious circle of obstruction, desaturation, wakefulness, and resaturation. That reperfusion injury stops, no more oxygen free radicals, their everything starts getting better. Their blood pressure starts getting better, their anxiety level, agitation level starts getting better, or all pro-inflammatory changes starts returning back to baseline. So their comorbid conditions are being controlled. So that's why in previous slide, when I was trying to convey that why comorbid conditions control is important, it tells you indirectly basically the control of obstructive disease. So people who are non-compliant with OSA, like in some country, let's say we put someone on CPAP and that patient says CPAP is not helping me a lot. So we have missed something. We send those patients to ENT surgeon and they do sleep endoscopy. They see that this patient never obstructed. When he fell asleep, this patient has a big uvula. So that uvula is, is a troublesome. So then the management is not CPAP. Management is uvulectomy. Or we do a sleep endoscopy, and ENT surgeon finds out. They write in their note that when this patient falls asleep, there is no constriction at the upper airway level, only his tongue falls back. Then what to do? We cannot optimize his or her obstruction with CPAP. What to do? That patient need to have something with the tongue. And in the literature, you can see that now a lot of people changing their life, they are putting hypoglossal nerve stimulator. They just switch it on while they sleep. So their hypoglossal nerve keeps firing and their tongue never falls back and they got better. But again, whatever the etiology of obstruction, why they are developing these comorbid conditions, answer is reperfusion injury, free oxygen radicals, and they are initiating all the endovascular and dysfunction, and they are developing this hypertension due to chronic hypoxia of pulmonary vessels. They are developing pulmonary hypertension. That pulmonary hypertension is continuously bothering right heart. They're developing right heart failure. These pro-inflammatory markers are initiating atherosclerotic changes in the coronaries. They are developing coronary artery disease. So if you do root cause analysis, you find the cause of obstruction. If you correct it, whatever the treatment is, CPAP or uvulectomy or hypoglossal nerve stimulator or some jaw surgery, somebody has a maldevelopment of mandible or maxilla and they need to undergo the mandibulectomy or maxillectomy. If you are able to correct the cause of obstruction, their comorbid condition gonna be better in the future, and maybe at certain point of their life they become off medication. So it is very important. Okay. So during these, so that's why this metabolic syndrome is always associated with these obese people. Okay. So these three bullet points are very important. Let me read it for you. Patient with untreated OSA undergoes cyclic episode of hypoxia and reoxygenation. Such activation leads to elevated level of pro-inflammatory cytokines and potentially oxidative stress of vascular endothelium, which induces an even more heightened state of systemic inflammation in obese patient with OSA. So which markers? Everything like these are nasty stuff, very bad chemical, interleukin 6, CRP, leptin, tumor necrotic factor alpha, interleukin 1, reactive oxygen species. Okay, they really affect the adhesion molecule at endothelial level, like ICAM1, VCAM1. So we are not here to memorize this. I just want to give you the overview that how OSA turns someone to have a certain number of clinical conditions. Okay. Again and again, the message is same: OSA and metabolic syndrome. The main etiology is reperfusion injury, free radicals, and a disaster. And these things happen over certain amount of period. Okay, so key is that if we educate ourselves, despite of having resources or not, but knowledge, it's not expensive. Somebody taught me in a systematic way. So that's why I'm trying to, generate the same message to all physicians. So at least if they know, they can try based on the conditions or based on the resources available. So this is a very busy slide. I'm not gonna read it. So basically, key is that if someone is morbidly obese, he or she has to go through multidisciplinary team approach like pulmonology clearance, pulmonary function tests like spirometry or CPAT or ABG, whatever, cardiology clearance, baseline 12 lead EKG, and echocardiogram. If further testing is indicated, cardiologists need to decide it. So we have to clear everything before we try to anesthetize, okay? And airway control is very important in these patients. Being an airway expert, I'm not saying it, they are anatomically difficult and physiologically difficult. Being an anesthesiologist, we just see the patient, we say, hello, how are you? What's up? What's going on? Good morning. My name is this, that. So we just say them, open your mouth, show me your tongue, show me your teeth, any capping, crowning, chipping, and the airway assessment is done. No, you have to develop your habit. Always scan patient for difficult airway in terms of anatomy and physiology. Anatomy, you do certain tests like Mallampati. If someone is having high Mallampati scoring, of course, it tells you the relationship of tracheal structure in relationship to other oral structure like tongue, tonsil, uvula. Okay, if someone is having less thyromental distance, it automatically tells you that there is less space or less room in the oral cavity. So relationship or position of oral structure may be difficult or may be altered. Maybe that patient with less thyromental distance has a very inferior trachea. And when we eh, do DL, when we do direct laryngoscopy, right? Sorry, I'm saying DL, direct laryngoscopy. What we are trying to do, we are trying to create a vector from our naked eye till the cords. And what we are aiming to bring all structure from teeth till the cards in one plane. But if someone is having less TMD, of course, we won't be able to generate a vector so that we can see a card, and we won't be having enough room that we can swap his or her tongue to left side and throw the tube down the cards. So most of the people do it. But what we are missing, we are not scanning any patient for physiological difficult airway. What is physiological difficult airway? Like obese people, how they are difficult? Large tongue, this is anatomy. Large body size, oh yes, this is physiology. Not very, liberal movement of diaphragm due to increase intra-abdominal pressure, less FRC, okay, more oxygen consumption. For example, in a normal healthy patient, we have a reserve of 1000 ml of oxygen. But once that 1000 ml of oxygen go via artery to capillaries, to the cells, to the veins, comes back, 750 ml comes back. Okay, so with 1 minute, with each cycle, 250 ml of oxygen is being utilized by a normal healthy person, let's say a weight of 70 kilos. So they are able to tolerate apnea till 2 to 3 minutes, but these patients not. So it means they are difficult airway. Doesn't matter they have a adequate TMD, they have a low Mallampati like 1 or 2, very big mouth, small tongue, but again they are difficult. So people will laugh at him. Why is difficult? You can say it's physiological difficult. Or someone is a PEDS patient. They have very less oxygen reserves. They have very high metabolic. They are physiological difficult. For example, someone is having altered metabolic profile, like they are having severe metabolic acidosis, and it is being compensated by respiratory component, right? They are hyperventilating. So their whole metabolic profile is being supported by respiratory system, right? So these patients are also physiological difficult. Why? Because they are not going to tolerate a lot of changes in intrathoracic pressure, which we do while anesthetizing someone, and they're not going to tolerate apnea. So they are also physiological difficult airway. So what I am trying to say, when we are doing area, examination of area of interest, like airway examination, always scan your patient for regarding anatomy and physiology. And the NAP audit 4 says that in obese people, they are more difficult in terms of airway management if you compare them to people with normal BMI, and they are having 80% more difficulty. Okay. If someone is morbidly obese and high Mallampati score of 3 or 4, you should assume that it's very hard to face mask ventilate them, and it's very hard to intubate trachea in them. If someone is having neck collar size of more than 42, it also predicts difficult tracheal intubation. If someone is having BMI more than 50 kilogram per meter square, this is an independent predictor of both difficult intubation and face mask ventilation. Okay. Presence of beard in a normal person alerts anesthesiologists difficult mask. And if they are obese also, it's a nightmare. And if someone is having system of reflux disease, symptoms of reflux disease, so they are at risk of aspiration, it means they are difficult airway. So always have a RAM position for them. Try to have more than one plans of intubation. Like even if you're planning to do direct laryngoscopy, try to have a video laryngoscope around if you have one. Okay. And you must have a backup plan if you're unable to maintain or secure the airway. Try to wake them up. Okay. So another concern, that do they need aspiration prophylaxis? Do they need preemptive analgesia? For me, yes, but non-opioid analgesia, like maybe you can give them PO Tylenol. Sorry, here they say Tylenol, PO paracetamol, PO pregabalin, some aspiration prophylaxis like some H2 blocker, and so everybody knows about it. I'm not going to dig this detail out. And while selecting their drugs, their whole body physiology is different, so they have altered pharmacology also. So different drugs are being dosed on different weights. So probably we need to know few body weights in these people, like what is total body weight? Total body weight is that when we stand on a scale and scale tells you a number that this is your body weight, this is total body weight. What is lean body weight? Lean body weight has a very complicated formula you can see on the left side section. But ideally, they say that if we talk about lean body weight, it rarely exceeds 100 kilo in men and 70 kilo in ladies. Okay. And what is ideal body weight? How you calculate it? Height in centimeter minus 100 in male and height in centimeter minus 100 in female. And what is adjusted body weight? Adjusted body weight is lean body weight plus 40% of total body weight. Okay. So these are few medications. Maybe people ask you in oral boards or Viva exams that which medication you need to select based on different body weights. So if it's a succinylcholine, succinylcholine, it's always on actual body weight. Okay. Most of the things like Sugamadex, antibiotic, low molecular weight heparin, neostigmine, some opioids, they go with adjusted body weight, which means ideal body weight plus 40% of excess. How you get this excess? You need to subtract total body weight minus lean body weight, and you take 40% of that. But please double check it because it's hard to memorize. So maybe someone check it and I am wrong. Please double check it, the how to calculate adjusted body weight. And these are few medications like propofol, induction dose, thiopentone rarely being used. Maybe people who are very, very senior, they may have been using it, but now propofol is available everywhere. Fentanyl, rocuronium, etracuronium, morphine, paracetamol, bup, lido, they go with the lean body weight. So perioperative management, it's a different topic. So monitoring is difficult for them. Sometimes their arm size is very big. So it is recommended in literature you can put a non-invasive blood pressure cuff on their forearm. Induction is tricky, and most of the time it's RSI, and they become really hypotensive or they crash on induction. So if you give a smaller bolus of ephedrine or phenylephrine within inducing rapid induction, it's always helpful. Analgesia is very important. Try to use the non-opiate based analgesia. Try to opt for multimodal analgesia. But if you really need to use opioid, use a short acting one. Positioning is very important. How to maintain their anesthesia. And it's hard to control them on an emergence. So probably sometime they move a lot, okay, and their IV falls out. So I always disconnect the IV drip from their IV during emergence, and I let them move, and I extubate them, and I use a little bit of propofol to calm them down. So it's again a trick. Somebody may be very anxious and on emergence put a large bolus of propofol and they obstruct the airway, the situation changes. So if you don't know some business, don't try it. Okay, but if you need to learn it, you need to see someone who is doing it. Hang around some expert, they will teach you. Okay, so post-operative again, how you gonna monitor their pain? Because if they are pain and some morbidly obese with OSA got some abdominal surgery, they are already obstructing and they have respiratory compromise already. And if they are not pain-free, they are not gonna breathe properly, and they're gonna develop basal atelectasis and this and that, and then another insult. So it's very important. It's very important to monitor them, decide with the team, decide with the nursing, everyone that, hey, I have this high BMI patient, 400 pounds, we are doing sleeve gastrectomy, I'm bringing him back to PACU. Would you mind to get CPAP machine? Or we need to talk to surgeon that, hey, we cannot take this patient to regular flow. This patient need monitor bed, or HDU, or step down. So it varies case to case. And there are few things like OSA. Once perioperative screening is established, efficacy of anesthetic strategies in perio period will need to be evaluated. Currently, no randomized controlled trials compare the safety of various anesthetics in perio period. Avoidance of respiratory depressants such as sedatives, narcotic analgesics is recommended. The ASA has recommended consideration of modified perioperative monitoring. While there is overall consensus that perioperative risk is related to the degree of OSA or nature of the surgery, specific data regarding perio managements are lacking. So there are a lot of educational gap. OSA is a very important topic. If someone is a good researcher or someone is interested in research, review the literature, there are many more questions need to be answered. So there are a lot of educational gap in this topic. Authors conclude by acknowledging that while episodic sleep-related desaturation and incidents of unexplained cardiorespiratory arrest may be attributable to undiagnosed OSA in surgical patients. This connection has yet to be tested by RCTs. Furthermore, whether or not altering anesthetic technique or perioperative monitoring can modify such risk, if they prove to be real, remains to be seen. Another educational gap. Thank you very much. Let's do some question if you want.
Bilal, thanks a lot for your wonderful discussion. There was a question here by Dr. Naseem that what intraoperative anesthetic choices can minimize postoperative respiratory complications, and which commonly used sedative should be avoided in PACU? This is a question, but I saw here.
Okay, a good question. Uh, so even I few last I read few slides. Still, there is no definitive thing like if we talk about GA maintained on inhalational or TIVA. But again, it depends that how smart you are. Let's say if you are doing GA with gas, so it's always beneficial to dial down the gas when they are closing abdomen, and if patient move, the boluses of propofol are helpful because it takes a while to get the gas out of the system, especially people who have a lot of adipose tissues. Sedative, we have very high threshold for the sedative. In terms of use of sedative, people who have high BMIs are people who have very high AHI. So use of what we do here in our center, we always plan our analgesia and sedatives intraoperative and post-op based on AHI. If someone is obese, morbidly obese, and AHI is less than 15, we sometimes we are very liberal. We just use in standard. But if someone is having AHI of 80, it's very tricky to use even fentanyl on them. And of course, other depressants like midazolam or something, we don't use it at all. And we try to go for the regional technique. We have a separate regional team and available at all the sites. So they are always helpful to do a couple of blocks like QL blocks, tab block. Even surgeon do here tab blocks, rectal sheath blocks, or central and axial block if it's a very long standing surgery. But of course, opioid sparing is helpful. But the main thing is that you need to look at the body weight and cause of obstruction and what is AHI on sleep studies, which is apnea, hypopnea index. So based on that, you can change your recipe every day.
Okay, Bilal. Actually, I don't think so. Any other question? Yes. Putting CPAP on post-abdominal surgery patient may cause actual harm. High flow nasal oxygenation is a better choice. What's your recommendation? CPAP on post-abdominal surgery patient.
Yeah, it can be, but if you have to use, you can use it. It is always risk versus benefits, right? So if you feel that the patient is obstructing and CPAP is not helpful, and if we use CPAP, it's gonna affect the surgical outcome. So probably keep intubated that patient, and once the healing is in a good position, we can extubate that patient. But again, it varies from case to case. It depends on the agreement between different teams, like ICU team, surgeons, anesthesiologists. It's not a one-man show. And what was the second question?
Mm,
What was the
please ask.
second part of this?
High flow nasal oxygenation.
High flow nasal oxygenation is very helpful. High flow gives humidified oxygen. Patient tolerate high flow, like it don't cause any nasal trauma or anything because it's a humidified oxygen. It washes out CO2 even from anatomical dead space. With the high flow, it gives a peep to upper airways. Like you can give 70 liter per minute with high flow. So when you increase flows from 30 liter onwards, for every 10 liter, it adds a peep of 1 centimeter water to upper airways. But to get all these benefits of high flow, the main condition is that upper airways should not be obstructed. But if it's obstructed, high flow not gonna help it out.
Yes. Bilal, because a lot of people are here on board right now. So I will just ask you because I have to finish. I have to go to pray. If you can just briefly tell about the fellowship pathway which you choose, because so many people, they don't have any idea and any understanding about how to catch the fellowship program. So I would request you to quickly in 2 3 minutes just explain how this pathway can be chosen. I will just take another because I will record this clip separately. Just give me a second. So this discussion is finishing. Just give me